Welcome to the Voices of Healthcare Equity. I'm Kim Tranquata, founder and CEO of the Healthcare Alliance for an Equitable World, and your host on this journey. Our organization, driven by clinicians, is on a mission to address global healthcare inequity using telehealth solutions. Together, we're building a community of healthcare professionals committed to making a scalable impact on global equity. Join me in insightful conversations with global health innovators as we explore the current and future state of healthcare. Be a part of this mission. Let's create lasting change together. Today, it is my great pleasure to introduce Dr. Neda Fuddle. Dr. Fuddle is an infectious disease specialist, of medicine at the University of Nebraska Medical Center, and Assistant Dean of Diversity, Equity, and Inclusion Educational Programs. I was honored to meet and hear about Dr. Fuddle's work with Project ECHO at the Meadow ECHO Global Conference in September 2023. In addition to a highly accomplished career in academics, research, and medicine, Dr. Fuddle has worked to support and train health workers in Sudan to rapidly increase their emergency response, treatment, and capacity since the civil war started in April 2023. Welcome, Neda.
Thank you so much for having me, Kim. It's really a pleasure and an honor to be here today, and I really look forward to this discussion.
I am honored as well. I always like at the beginning of our podcast to offer our guests the opportunity if they have any disclaimers of affiliates or conflicts of interest that they want to put in the front of the podcast.
I usually tell people that I wish I did, but no, I don't have any.
Awesome. Well, I'm ready to get into it. I'm super excited about this conversation. Tell us, please, a little bit about your background and how you have come to be involved in healthcare and health equity.
Yeah, so that's a very loaded question. And I think I usually get asked that questions when it applies to academia. But for this specific podcast, I'm probably going to offer a very different answer. So I am a Sudanese American. I actually grew up, went to school, went to medical school in Sudan. And I moved here to the US after finishing medical school and went through the traditional path of international medical graduates, taking the USMLEs, did my residency at University of Illinois, Urbana-Champaign. And I was not decided at this time what field I wanted to end up in. So I took a few years where I worked at MD Anderson Cancer Center in Houston and worked in palliative care, emergency medicine as well, which was an amazing experience that just kind of opened my eyes to this concept of holistic care and equity and helping people at the end of life when no other biomedical interventions end up working. And that, the compassion of healthcare workers can equate so many other biomedical interventions. And sometimes we forget that a lot of what we can offer to patients sometimes can just be our words, our encouragement, the way we reframe hope, and how to think about that. And I really enjoyed that experience. But around the time, there was also an outbreak of HIV in East Africa. And that came very close to my heart because that's my region. Those are my people. So I felt like I need to think about how am I going to help my people? And, generally speaking, unless you came here with an idea that I am going to be here forever, most immigrants I find, especially from Africa, especially from Sudan, always have this idea of, I want to come back to my country. I want to go back and I want to live there. I want to contribute. So at the time I was in that mindset. So I felt like, okay, what can I take back in terms of knowledge and capacity building, whether I end up living there or not? I wanted to contribute. So I chose infectious diseases as a field. And I chose infectious diseases because I was really passionate about HIV. Because at the time, there were so many advances in HIV treatment, and there still are. And it just really changed the whole epidemic from a deadly disease to a chronic disease. So I trained in infectious disease at University of Texas in Houston Science Center. Again, it was an amazing experience. Accepted a job at University of East Carolina University, which is part of the University of North Carolina system, and stayed there for 5 years, managed the HIV program over there. And that was a very enlightening experience when it came to health inequities, because I saw it almost every single day in my clinical, my administrative, my research work, that there are just so many health inequities when it comes to HIV in this country and globally. Actually, if you think about HIV, 70% of the cases in the world exist in sub Saharan Africa, while only 12% of the population of the world, 12 to 14%, I think the last census, lives in sub Saharan Africa. So that's just an unbelievable disparity when you think about it. And this is a preventable disease. This should not exist, especially when it comes to things like mother to child transmission, transmission through IV drug use, even sexual transmission, because now we have prophylaxis. So there is just a very vast degree of inequity. Also in this country, when you look at the populations that are highly affected by HIV, they tend to be ethnic, racial minorities, and gender and sexual minorities. And that has to do a lot with the structural inequities that are built in the system, a stigma, and et cetera, et cetera. So I find these areas I'm naturally drawn to those areas and helping the underserved, helping uncover inequities. And I kind of just found myself naturally being drawn to doing research in HIV disparities, and I spent a lot of time early in my career looking at these disparities and what are the drivers, what are the potential solutions, etc. And now moved more into like implementation science of like practical solutions to address these disparities. But again, that longing for being able to give back to my home country, to my region, to my people, that always has been there. And I got engaged with some traditional global health activities where I go back home and give lectures. I go to different regions, even as a visitor, and end up, giving a lecture in the regional university or something. And I just had a feeling that that's not enough. You can't just drop in, helicopter in, do something, and then leave without actually even knowing if you made an impact. I mean, there's always that, like, wow, this was great, that feedback that you get at the moment. But then, is that really what the people need? Sometimes you don't even know that's what they need. But I find a lot of us in academia are okay with this immediate gratification that, oh, this is great, and then you move on. But in other ways, when we think about patient care or research, we know that that's not actually how it works, right? So why are we okay with this when it comes to issues related to global health or global knowledge transfer? So when I came across Project Echo, it was actually early in the pandemic. I found that to be just like exactly what I needed. And I'll stop here because I think we're going to have spend a lot of time talking about that. But this is just a little background about me and how I kind of went from one field to another throughout my career.
That is 5 lifetimes worth of introduction. You are amazing. Um, so, I mean, HIV is such a high impact area, and it's clear why inequities are at the forefront in HIV care, and how seeing that you just went for the highest impact area that you could help not only the people of Sudan, but globally. Um, Even today, these inequities exist because they're baked into society, right? They weren't a product of the time of when HIV happened. I mean, we've evolved somewhat, we've evolved the science, but we still have the social structures that make HIV treatment and eradication very much a marginalized issue. Tell us a little bit about how you see that playing out, not just at Sudan, but here in the United States as well.
Yeah, and I can actually start with here because that's where most of my work around HIV is. So I think you framed this really well. This is not an isolated thing. It's not an incidental finding. It's something that's actually is a product of the system that we live in. And this doesn't only apply to HIV, but you're very right that HIV is actually um, one of those very obvious disparities that we can't really ignore. We can't attribute it to race because it's very clear that race here is not biological. It is a structural issue, it's a socio political issue that's leading to this to happen, right? And if you think about the HIV epidemic and how it started in San Francisco, in New York. It was a majority white male gay men, and then from there started, kind of spreading, so to speak. But also there were a lot of issues that were uncovered about how the disease was initially managed and transmission. We didn't even know what we were dealing with at the time, right? We thought it was cancer, then we thought it was infection, and it took us years to find out that this is actually a virus and we can test it and so forth. So it's really hard to know what happened during that time in terms of how the different populations were impacted, because the populations that had the voice were the ones who were actually out there talking about it and advocating for it. And that made a substantial impact on policymakers, on research, moved the needle really quickly. So we were actually able to pretty quickly, considering the science at that time, come up with treatment. So by 1996, we have what we called highly active antiretroviral therapy, which now we say combination ART. And by 2000, we saw a marked decrease in HIV mortality, in opportunistic infections. This is only 40 years later, and the decrease was just so phenomenal. But at the time, we kind of didn't pay attention to other populations that were slowly getting impacted by this disease. And soon after, we found this major outbreak in Black women. And that kind of took everyone by surprise that, oh my God, the incidence in Black women is absolutely substantial and we need to pay attention to this. So we had this knee jerk reaction of developing all these interventions to address it. And then before we know it, we saw this massive increase in young gay Black men. And that, again, was like a kind of a neglected or a population that we didn't really pay attention to. But knowing the route of transmission, that should have been expected, I think. And if you think about the concepts of intersectionality when it comes to that population, specifically the young gay Black men, there are so many factors that work in tandem to lead to that increase in incidence and that disparity. So you have a population that's highly impacted by systemic racism, by the criminal justice system, by stigma, by lack of employment, by issues related to access to healthcare, issues related to access to education, issues related to access to just life in general. Environments that are not healthy around them. So all of these things worked together to make this a problem, and we have put a lot of effort as a scientific community, as a clinical community, to address this. And there have been some improvements, I have to say, in the past 10 years, but those improvements are not yet to the point where there is an equity, so to speak, in healthcare access. And it depends on the region too in the country. So if you look at where HIV is happening in the country, where is the highest incidence, is a very specific region in the country, which is mostly southeast of the United States. So then that also begs the question, what is happening in those regions? there is a long history related to slavery, related to lynching, related to discrimination that was happening in those regions. There are policies in those states that specifically make it difficult for Black people to live in those states, right? So it's not, again, it's not incidental, it's not accidental.
And Tuskegee.
Tuskegee, you look back at the history of sterilization of Black women, all of these things, you know, not only in that region, but they were quite very common and predominant in those regions. So these are things that are building on each other, obviously. So there is that very long history. There is also, if you look at Africa and sub-Saharan Africa, I feel like that's also a historical extension of what happened here in the United States, because always we don't think about the continuity of enslavement of Black people. And if you think about that in a continuum, that started in that region in Africa, right? And it was related to colonization. It was related to the history of oppression that was happening in that region. And that just changed geographically and moved here to the United States. So it almost became two separate phenomena or two separate epidemics. But to someone like me who lived across the two sides of the Atlantic, I mean, to me, this is just a continuum. It's not really that different. So I feel like if we put this all in perspective, these global inequities are related to the same exact factors. They're not really that separable. And if we think about it that way, I think we will be able to be more effective at thinking about solutions. I feel people like sometimes get surprised, like, oh my God, yeah, this is also happening in Africa. And I'm like, duh, yes, it is happening in Africa because, it's the same issues. And especially now with globalization, the world is much more smaller than we think it is. And that was really evident during the COVID pandemic because the rumors we were hearing here in the US, there were the same rumors in Sudan, there were the same rumors in India, there were the same rumors in Europe. So it was not that separable. So anyway, so that's kind of my view on health disparities, especially related to HIV.
Thank you for that. Dr. Fadl, I'm not young enough to not have experienced the start of the HIV epidemic in my training. And I was training in Brooklyn at SUNY Downstate with a large Caribbean and immigrant population. And, this is well before 1996 in the 1990s. And we watched very sadly and helplessly as lots of babies, Black babies, died of AIDS in the hospital. Um, and patients that came into the ED were men and women. I mean, if you have babies that are dying, it's no secret that women are being affected by this. Um, and, historically, it wasn't until Ryan White, a white child, became the public face of children with HIV that people started paying attention to. And I'm going to put this in air quotes. People that are listening can't hear this. People started paying attention to the quote, innocent victims, but there's no reason to think that the gay men weren't innocent. So we had already created a stigma around HIV that it was um, a punishment, a cancer, right, for people in a certain group. This repeats, right? I think you mentioned it repeated with COVID. We keep making these mistakes of infectious diseases being ascribed to groups of people, forgetting that in the great scheme of viruses, bacteria, humans, and animals, those organisms don't care about our silly groups. If it affects one, it's going to affect all. And so we saw this again play out when COVID was a disease that somehow was only going to affect the people in China and somehow not going to travel across the globe and affect others, and started again in the West Coast and quickly spread to areas with diverse populations where people kind of said, it's not going to be me. We need to learn the lessons. um, because it's the right thing to do. I mean, I think a lot of people learn the lessons for selfish reasons because eventually it's going to affect you and it's going to affect somebody you love. But why don't we just do it because it's the right thing to do? Because actually, gay men, people that inject drugs, women, people in Sudan are actually valuable people that deserve health and will do wonderful things for the world if we treat them right.
Yeah, absolutely. And you know, it's puzzling why we don't think that way, right? But we also have like major catastrophes, man-made catastrophes happening in the world right now. So we're really good about like being our best enemy. So but you know, one of the things that while you were talking or thinking about is that one of the things that we often don't pay attention to is that health equity is actually cost effective, because you know, for people who just kind of think about things from that business perspective, there've been studies after studies showing that if we do things right and if we create health equity, everyone will benefit at the end of the day. The cost of healthcare in this country is the most expensive in the world, yet we have a very sick population. We have people who are not able to afford the simplest medications, you know, things like metformin for diabetes or lisinopril for high blood pressure. We have people who choose food over medications. You know, some of our elderly patients of Medicare, regardless of race or ethnicity, they're suffering to just make ends meet and have to choose between just eating or taking their medicine. And we are still not there to where we can just say that, you know, we, even the advantaged population in this country, do not live a healthy life because of the way the structure is and the system is. So I think if we focus on health equity, it's going to be beneficial to everyone. It's not just for the populations that are highly impacted, but everyone at the end of the day will benefit from a better healthcare system that's most accessible, that's cost effective, that's cheap, you know. So that's something we really need to emphasize.
Dr. Fadl, thank you. We're going to take a brief break and we're going to return to continue this amazing conversation. Please join us in part two with more from Dr. Neda Fadul.